my few years in private practice between Free State and Cape Town taught me that I knew very little, too little about primary immune deficiencies. And these patients are actually out there. And I think, well, I suspect that I probably missed many in my career, because once I knew a little bit about them and started to look out for it, I ended up with a whole collection of patients that I'm now following up still, who see me on a regular basis or come for monthly polygams, etc. And my experience has been, when I talk to physicians and clinical hematologists and doctors all around, that apart perhaps from the pediatricians, most people have a similar experience, that they perceive these conditions as very rare. And yeah, that was my perception as well. And yes, they are rare, but I think likely underdiagnosed. So yeah, I think today is going to be an education for me, for hopefully for all of us. I'm sure we'll all learn something. And I'd like to hand over the reins in a minute to Jaco Joubert. But now let's just see, I think, Estelle, you've already clicked the record button, am I right? I think so. So let me introduce Jaco Joubert, who's actually chairing today's meeting. I'll be the housekeeper on the side. Before I do that, just a big thank you again to Prof. Estelle Verburg, Elzaan Jansen van Rensburg, Jani van Wyk, Melanie Davids, everybody in the team from Blood SA that are all working together to make these deep dives administratively and logistically and practically and organizationally possible. We really appreciate that. Please, please, please make comments in the chat. Let's make this lively. You can ask questions. You can put in just sort of your own experiences. We'll also open it up for live discussion a bit later. And then at the end, there will be a link that will be posted in the chat box that you can click to register your attendance for CPD purposes. So with that, Jaco Joubert is a hematologist. He's head of the Department of Hematology and Cell Biology, where I was very fortunate to work for 12 years on the clinical side. And that's in the NHLS at Universitas Hospital and University of the Free State in Bloemfontein, South Africa, for our visitors from overseas. He did his medical degree at the University of Pretoria, his MMed, and his postgraduate diploma in transfusion medicine. Very proud of Jaco for doing that too. And his PhD at the Free State. And he's got a broad range of interests, including laboratory hematology, transfusion medicine, hemostasis, and they've got very interesting preclinical animal models to investigate hemostatic disorders. And a lot of new drugs are also tested in that center. So I only have great memories working with Jaco, not a single negative. And what a great man, what a great opportunity to have worked with you, Jaco, for a couple of years, also during your training. Very happy to see you in the position that you are today, to have seen you grow over the years. And we welcome you here, and I hand the reins of the rest of the meeting over to you. Thanks, Jaco.
Thank you, Prof. Louw, for that very kind introduction. You're making me blush even more than I usually blush, so thank you for that very kind introduction. It gives me great pleasure to welcome our two speakers this afternoon. We've got Anneke van Marle and Pieter de Waal, who will be representing Bloemfontein on this forum. And I would also just like to thank you also, Prof. Louw, for inviting us to participate on this very exciting initiative with the deep dive. We think it's a truly worthwhile initiative that you guys have started, and we're very glad to be able to participate in it. So you guys may be familiar with the saying that if you are the smartest person in the room, you are in the wrong room. So I can quite honestly tell you the only time I am the smartest person in the room in my department is when I'm alone in the room. So I'm very fortunate to have our two speakers here this afternoon. First off, we'll have Anneke van Marle, and then Pieter de Waal. So I'll first introduce Anneke and then give some more details on Pieter just before his presentation. So Anneke van Marle is a hematologist here at NHLS Universitas and the University of the Free State in Bloemfontein. And she obtained her undergraduate degree cum laude at the University of Pretoria in 2009 and her postgraduate qualifications here at the University of the Free State in 2018. She was awarded the Miller Potgieter Medal for her MEd research publication, of which we are very proud. We always use her to get some reflected shine for the department, so we're very proud of her. And she's involved in laboratory diagnostics and research, and is a University of the Free State lecturer involved with undergraduate and postgraduate students. So she has a special interest in flow cytometry, and I think that's where her interest in primary immunodeficiency disorders was actually peaked through her interest in flow. But she's also interested in hematology oncology and is actively involved in the hematology clinics of both Universitas and the Robert Mangaliso Sebukwe Hospital in Kimberley. So without further ado, Anneke, welcome, and thank you for speaking to us today on this very interesting topic, and we're looking forward to your talk. Thank you.
Thank you, Jaco. Thank you for the kind introduction. I'm going to stop my video now and share my screen. Can I just confirm, Jaco, can you see my screen?
Yes, we can.
Oh, okay, wait, actually, I needed to do something. Sorry, I actually want to unshare and just share the audio. Okay, I'm going to start the talk with a small video clip. Please stop me if you cannot hear the sound of the video, and then I'll introduce my topic further.
For as long as anyone can remember, men have been willing to risk their lives for a sense of adventure, for a taste of fame, or to prove their love. Of course, it's hard to show the world what you're made of when you're allergic to just about everything. I'm allergic to diapers, hands, scissors, grass, even my parents.
Okay, so this was a small video clip from the 2001 movie Bubble Boy, which was both described as a blockbuster disaster as well as an underappreciated gem. But obviously the reason for sharing this clip is because this was a boy that had SCID, but also I thought to use this as a metaphor because just like this boy safely contained within his little bubble, I realized when I started preparing for this presentation that my knowledge on primary immunodeficiencies was also very much contained in a little bubble and stored away, and it hasn't been accessed for a while. And so I thought, well, maybe it's time to revisit this topic and basically let's burst this bubble and let some of the information leak out again. So quite a few things have changed since I last looked at this topic, and one of which came as quite a shock to me. It's really referred to now as inborn errors of immunity. That's now the preferred nomenclature. So inborn obviously referring to the fact that this is inherited and this can be transmitted to future generations. Error referring to the pathogenic mutation in the DNA, and that underlies the patient's phenotype. And then of course, immunity being the aspect of our bodies that are affected by this error. So just as an introduction, these are heritable disorders, almost always affecting a single gene. And this results in either the absence, the decrease, or the dysfunction of critical components of our immune system. To date, more than 400 different inborn errors of immunity has been recognized. But the basic hallmark of all of these diseases is that it has an increased susceptibility to recurrent microbial and viral infections. And often these infections are prolonged and life-threatening. They are poorly responsive to treatment. And these patients are predisposed to allergies, autoimmune and autoinflammatory disorders, and also malignancies, especially lymphoma. So they usually are detected early on in childhood, within the first year of life. But some of them, such as the combined variable immunodeficiency, and to a lesser extent also the chronic granulomatous disease, can be diagnosed only later in life, as late as the 5th decade of life. But by far the majority of inborn errors of immunity will probably go undiagnosed. These patients will die of some unknown cause and will never have been diagnosed with their underlying immunodeficiency. It's said that in the United States, it takes about 12 years from onset of symptoms up to the point where the patient is actually diagnosed with an inborn error of immunity. So roughly about 6 million people are currently afflicted worldwide. And if you think of the 2021 world stats, we've got about 7.95 billion people on Earth. So that's less than a percentage of the world population. So like Prof. Lowe said, we think of this as quite rare, very rare diseases, and we'll probably never see it. But actually, if you combine all the different immunodeficiencies together as a single entity, they are very prevalent. It varies from 1 to 5 per 1,000 individuals that are affected by some form of inborn error of immunity. The prevalence obviously also varies according to the geographic region, and it may be influenced by the practice of consanguinity. In the United States, they say it's about roughly 130 people per 100,000 that are affected, according to stats. But in the Middle Eastern and Northern African countries, it's only reported that there are about 0.8 to up to 30 per 100,000. And that's probably just because it's underreported. In South Africa, we have no official data. But this is a calculation from Rousseau et al. That was actually based on a calculation earlier done in an article by Elliott et al. That was in the SAMJ in 2014. They said if our population is roughly 60 million people, then we should be seeing anything between 4,000 and 73,000 patients with PIDs. But in fact, only or less than 500 cases have been reported at the time of the article written by Rousseau et al. In 2018. Possible reasons could be that there's just underappreciation, or probably more likely just a lack of knowledge amongst the medical practitioners in South Africa. Also, we could say that patients may have limited access to healthcare, so they die before being diagnosed. Also, one of the common things they mention is the BCG vaccine that babies get at birth cause early neonatal deaths, which may be unrecognized. And then, of course, in South Africa, where we've got this high setting of secondary immunodeficiencies, HIV, TB, and other infective disorders, we probably are missing the underlying primary immune defect as well. So when would we know to think of it? Because many of us are parents, we've got kids, they are in creche or in kindergarten, and they get sick during the winter months. And often, recurrently, you have some snotty kid, and you just don't think much about it because, you know, that's kids. But at what point would you say to yourself, maybe this is something more, maybe this is not normal? So these children typically will have chronic recurrent infections. They are caused by atypical opportunistic pathogens, and it resolves very slowly or incompletely with conventional therapy. Up to 90% of children will have a triad of a positive family history, and keeping in mind that a lot of the PIDs are X-linked, it's usually the boys that are affected in a family. They require intravenous antibiotics to treat the infection, and they show failure to thrive. They would be especially stunting. Height for age would be more than 2 standard deviations below the WHO child growth standard medians. And again, not just a sick child, these are red flags, because remember, up to 6 upper respiratory tract infections in a toddler can still be acceptable. But when you have these red flags, this should worry you. This is severe. These infections require hospitalization or intravenous antibiotics. They are persistent. Patients never completely recover. It's unusual organisms or unusual sites of infection, recurrent infections, and like we said, it runs in the family. So what are the warning signs? It's a poster that many of you will have seen, and we all know the warning signs, but just to go through this again: 4 or more new ear infections a year, 2 or more serious sinus infections within 1 year, 2 or more months of antibiotics with limited effect, 2 or more pneumonias within 1 year, failure of the infant to gain weight or grow normally, recurrent deep skin infections or organ abscesses, persistent thrush in the mouth or fungal infections of the skin, need for intravenous antibiotics, 2 or more deep-seated infections, including septicemia, or a family history of PID. And again, having said that, still remember that only about 10% of children with recurrent infections will in fact have an underlying primary immunodeficiency. Still, the majority will rather have allergies or a chronic disease of sorts, or possibly an anatomical defect. But other things just to think of as well would be, for example, a family history of an unexplained death before the age of 30. When children with disseminated BCG infections, this first picture in the left upper corner, this is of a child with BCGiosis. They could have recurrent microbacterial or meningococcal infections. This is a little baby at the right bottom corner with meningococcal sepsis. Persistent oral or cutaneous fungal infections after 1 year of age, causing structural defects especially. Parasitic infections like Giardia lamblia, or pulmonary fungal infections, the Pneumocystis jirovecii. And then, of course, you could have complications from live vaccines. This little baby had a live vaccine in the thigh that formed a large thigh abscess. Chronic diarrhea resulting in non-healing wounds. This is from a little baby with leukocyte adhesion deficiency. And one can also think delayed umbilical cord separation after 30 days. These are other warning signs that should also alert you to a possible underlying immune defect. So now that we know what to think of it, great. What do we do about it now? What is next? We can't just start doing lots of laboratory investigations. You should have sort of a systematic approach. So before we know what tests to do, we need to know what are the options available to diagnose this condition. So the International Union of Immunological Societies come together every few years, and they sit together and they make a phenotypic classification for the primary immunodeficiencies. And the last update was in 2019. They are due to the next conference is this year. And according to the latest classification, there are 9 categories, and then a 10th category that's called phenocopies of the inborn errors of immunity. So for the rest of the talk, I'll basically go through the different categories so that we give an overview of the different types of immune deficiencies, and then also touch on the diagnostic approach. So this is a table from UpToDate just showing you the 9 categories with all the number of genes that have been identified in each of these categories and some of the examples of conditions. So just to remember, the vast majority of PID or inborn errors of immunity, 60 to 65% of all inborn errors of immunity are from the lymphoid or affect the lymphoid system. So T cells or B cells, either alone or in combination with other cells. And then of those, by far the most involve antibody deficiencies, so predominantly antibody deficiencies. These are followed by combined immunodeficiencies, phagocytic disorders, and then disorders of complement. So for the first category, these are the cellular and humoral immunodeficiencies, affecting both your T cells, that's the cellular component, and then your B cells, the humoral immunity. So it causes a combined immunodeficiency, but these patients lack syndromic features. We get the 2 major categories, your severe combined immunodeficiencies for the SCID, and then the less severe. So the severe combined immunodeficiency is your typical bubble boy. This is defined by T-cell lymphopenia, where you've got an absolute CD3 positive T-cell count of less than 300 cells per microliter. This is in children less than 2 years of age, but this definition will probably be revised because it's known now that children between, say, neonates versus 1 month versus 6 months old all have different reference ranges for the normal CD3 T-cell count. So this will probably be revised in the near future. But these patients have a profound lack of cellular or T cells and also humoral immunity or B cells, with or without a decrease in the natural killer cell number and function. And the B cell defects can either be because there's truly an absence in B cells, or there's just impaired T cell health. These children usually present within the first 6 months of life, and they will die within 1 year if they do not receive any treatment. They present with recurrent viral, fungal, and bacterial infections, and these would include opportunistic infections and those from live vaccines. So this is just a diagram showing you the normal T cell development and where the different genes slot in that would be associated with SCID. So a lymphocyte precursor going to the thymus, you would have in the early stages where you've got your double negative T cell. Very early on, you get your X-linked SCID. That is associated with mutations in the interleukin-2 receptor gamma chain, that common gamma chain that's found on the X chromosome. And this is the chain that is required in all the receptors of your interleukin-2 cytokine family. So interleukin-7, for example, that's critical in T-cell development, needs that receptor chain, and also interleukin-15, which is crucial in NK cell development, would also make use of the interleukin-2 receptor. So this receptor is very important in T cell development. A deficiency or a mutation, therefore, in this gene would require severe deficiencies in both your T cells and NK cells. So just to show you that historically we've divided SCID into those that usually the T cells are absent in all of the SCIDs, but with or without B cell function and NK cell function. So JAK2 is the tyrosine kinase that works downstream from your interleukin-2 receptor. So again, would also affect mostly T cells and NK cells. Whereas your ADA, or your adenosine deaminase, this is an enzyme that is important to convert your deoxydeaminase that is generated during DNA breakdown, which is toxic to lymphocytes, into a deoxyinosine, which is not harmful to lymphocytes. So this forms part of your purine salvage pathway. And if you have a lack or a deficiency in this enzyme, you get accumulation of these toxic metabolites in lymphocytes, all your lymphocytes. This would include B cells, and you would therefore have a profound combined immunodeficiency, this one where you would have no T's, B's, or NK cells. You think of interleukin-7, this is a cytokine that is very important in both T cell and B cell development in the early stages of B and T cell development. The RAG1 and 2 genes, these are the recombinant activation genes. They are very important in the VDJ gene rearrangement during the early stages of both T cell and B cell receptor synthesis, where you get the highly specific T or B cell receptor. And your Artemis is a molecule that is involved in DNA repair during this VDJ gene rearrangement. So these would only affect B cells and T cells, which have these highly specific gene rearranged receptors, and not so much NK cells, where you would expect to have more of a pattern recognition receptor. And then CD45, this is a tyrosine phosphatase that regulates Src kinases during the T cell receptor and B cell receptor signaling transduction pathways. So just showing you, this is a table highlighting the most important genes. So obviously there are more genes and gene defects that have been identified that can result in SCID, but these are the most common ones. And again, showing you the ones involved in VDJ gene rearrangement, which for example affect T's and B's, but not NK cells, ADA affecting all lymphocyte cell lines, and then something like your interleukin-2 receptor gamma chain, or JAK3, which is the downstream signaling molecule, mainly affecting your T cells. The less severe combined immunodeficiencies do not lead to death in the first year of life. They tend to have higher T cell numbers and functions, and there are, again, a lot of them. This is a table from UpToDate, again, showing you all the different genes that have been identified in this category. The two I thought to highlight is the hyper-IgM syndrome, and I'll explain now why it falls under this category and not your primary or predominantly antibody deficiency category, and then also ZAP70. So for the hyper-IgM syndrome, this is characterized by defective class switching. You have normal or increased levels of IgM, but deficiency in the other isotypes, and poor antibody functioning. So the most common cause would be the CD40 ligand deficiency. That's X-linked, and that's the CD40 ligand that we find on T cells, and it interacts with CD40 on B cells, and it's important for B cell activation and class switching. So you would obviously have a defective class switching in these cases. But also it causes a simultaneous T cell defect, because you also need the same CD40 ligand interaction for these T helper cells to interact with antigen presenting cells and then to become fully activated and further divide into its final effector T cell, whether it be a Th1 cell or Th2 or a Th17, for example. So this is why it's referred to as a combined, it's classified as a combined immunodeficiency. These patients have recurrent sinopulmonary infections. They can have liver disease, including cirrhosis, cholangiocarcinoma, hepatocellular carcinoma, osteopenia, and also an increased risk of hematological malignancies, specifically T-cell lymphomas and leukemias. So other causes of your hyper-IgM syndrome, if I could just show you here, it's mostly the CD40 ligand deficiency, the X-linked one, that causes a combined T and B cell deficiency. The other causes of hyper-IgM syndrome are predominantly B cells that are affected, and these would then again be classified under the category 3, which is the predominantly antibody deficiencies. The ZAP70 is an adapter molecule that is involved in downstream signaling from your T cell and B cell receptors, and it basically forms a docking station for this macular-molecular complexes that form and then downstream signaling. It's very important in T cell differentiation and function, and it seems to also be very important in the selection of CD8 positive T cells. They've looked at histological sections of of a thymus of a patient with ZAP70 deficiency. And when you look at the cortical thymocytes, there's an abundance of double positive T cells, both CD4 and 8 positive T cells. But then looking at the medullary thymocytes, there's an abundance of CD4 T cells, but a complete lack of the CD8 positive T cells. So it seems to be important, especially in cytotoxic T cell selection. The second category is the combined immunodeficiencies associated with syndromic features. So this is a heterogeneous group, but they all have unique clinical features and they have got well-characterized immune defects. There are numerous again in this category, broadly divided into subgroups that maybe involve, say, congenital thrombocytopenias, or those involved in DNA repairs, defects, or those that involve thymic defects. I'm just going to show you a few pictures to show you what this category would look like. There's, again, definite syndromic features. So the first picture is this of a little child with Wiskott-Aldrich syndrome. This involves the WASP gene, and this gene, again, is involved in cytoskeleton-dependent responses, including cell migration and signal transduction. So these children will have a triad of eczema, microthrombocytopenia, and then an immune deficiency with recurrent bacterial infections. The second picture is of a boy with DiGeorge syndrome. So this is also known as uvulocardiofacial syndrome, and that's the catch-22. These children have cardiac abnormalities, abnormal faces, thymic and T-cell abnormalities, the cleft palate, lip and palate, hypocalcemia, and then the defect being on chromosome 22. And this is a gene that is involved in sort of the development of the pharyngeal pouches. So the defect would then cause abnormalities in all of the structures that develop from these pharyngeal pouches. This is a little girl with ataxia telangiectasia. Again, here the gene would be that's affected is the ATM gene. It is a kinase that codes for the ATM kinase involved in DNA repair. And then this little girl has Nijmegen breakage syndrome. Typically, they've got the bird-like faces, microcephaly, they've got short stature, and then also the immune deficiency. It involves the NBN gene, which codes for the nibrin protein important in double-stranded DNA break repair. This is a boy with Bloom syndrome. Again, facial rash, facial abnormalities, short stature, and then immunodeficiency. And this is because of a defect in the BLM gene that results in abnormal helicase formation. The third category is the predominant antibody deficiencies. This is the most common inborn error of immunity, and these patients present with recurrent upper and lower respiratory tract infections, typically bacterial infections, and it is ear infections, sinus infections, pneumonia. And depending on where the defect occurs during the B-cell development, it will determine how profound your hypogammaglobulinemia would be. So looking here early on in the lymphoid, where both B and T cells are affected, something like ADA SCID, we mentioned already, would give combined immunodeficiency. But when you move down the B cell lineage differentiation pathway, you can either have your hypogammaglobulinemias, and B cells could either be absent or just decreased, or you would then have those that have just specific antibody deficiencies. Either hyper IgM syndrome, again, could fall in this category depending on the genes affected, or then selective isotype or subclass deficiencies. So just to highlight a few that you may have heard of, the Bruton tyrosine kinase agammaglobulinemia. This is the X-linked form. This Bruton tyrosine kinase is an enzyme very important in the transition between the pre-B and the immature B stage. So these patients have a complete or profound B cell deficiency and agammaglobulinemia, or severe hypogammaglobulinemia, with recurrent infections usually noted from about 6 months onward, because in the first 6 months of life, you usually tend to still have maternal antibodies that are circulating. The combined variable immunodeficiency is impaired antibody responses in spite of the presence of B cells. So these patients usually have low levels of IgG and or low levels of the other isotypes, but a marked reduction in memory B cells and antibody-producing plasma cells. This tends to only be diagnosed, or the onset is usually later in life, age 1 to 5 years, but as I mentioned previously, it can be diagnosed as late as the 5th decade of life. And there are many there's some of the gene defects that have been identified as, for example, mutations in ICOS or BAF or TACI, but by far the majority of patients that are classified in this group, the underlying genetic defect is still not known. But the underlying mechanisms seem to be either failure of this B-cell receptor to proliferate or to be activated by an antigen, or these B-cells are activated and they start proliferating, but they cannot produce any antibodies, or they can produce IgM, but they cannot class switch, or there's an abnormality in the glycosylation of the immunoglobulin heavy chain. Selective IgA deficiency is the most common of all immunodeficiencies. 1 in 800 individuals are affected. They can either be asymptomatic, or they will have this recurrent, the common cold with the cyanopulmonary viral bacterial infections. There's a strong association with celiac disease. And just to mention here, these patients are usually treated with broad-spectrum antibiotics because the commercially available preparations with immunoglobulins usually tend to have very low levels of IgA. And with the route of administration, which is usually intravenous injections or subcut injections, it usually doesn't reach the area of the secretory immune system where you would want your IgA to be, which is the mucosal surfaces of the GIT and the respiratory tract. And also patients that lack IgA can potentially develop anaphylactic reactions when they are exposed to the IgA, when they've been previously sensitized. So on that note, also, if you were to give these patients red cell transfusions, we tend to give them washed red cells where you have removed the antibodies or the plasma. The fourth category is the diseases of immune dysregulation. And this is an entity that's difficult to define clinically and also to diagnose, but the defect is basically underlying the self-tolerance, whether it be central or peripheral tolerance. These patients present with autoimmune diseases, with or without lymphoproliferation, and then of course the recurrent infections. So part of this group would be your familial HLH, which is these patients presenting with recurrent hemophagocytic lymphohistiocytosis, fever, hepatosplenomegaly. And this is because of a hypercytokinemia due to defective NK and cytotoxic T cell responses. And the genes that are involved here, such as perforin or MUNC13-4 or the syntaxin, these are all genes that code for proteins that are involved in the packaging, the transport, and then the release of cytotoxic granules. So on that note, if you look at HLH with hypopigmentation, again, a group of conditions presenting with HLH and then the oculocutaneous albinism. But if you look at these names, you may have recognized them also from the chapter in your textbooks on inherited platelet disorders or your thrombocytopathies, the Chiari-Higashi syndrome, Griscelli, or Hermansky-Putlag syndrome. And it's again because it involves proteins that are involved in granular trafficking and secretion. So again, the alpha granules and the dense granules of platelets are also affected. IPEX syndrome being your immunodeficiency, polyendocrineopathy, enteropathy, and X-linked. This is due to defects in the FOXP3 regulatory T cells. Apoptosis is due to your autoimmune polyendocrineopathy, candidiasis, ectodermal dystrophy. Here, the defect is in the AIR gene. So the AIR gene is a gene that is expressed in your medullary thymic epithelial cells, and it's very important during the negative selection in the thymus, where it basically tries to eliminate any autoreactive T cells. But when you've got a mutation in this gene or a deficiency in this enzyme, ultimately because of a gene defect, you would have escape of these autoreactive T cells. And then also your autoimmune lymphoproliferative disorder or syndrome, we've got defective apoptosis of lymphocytes because of abnormal caspases or again the FAS ligand death receptors that are affected. Ultimately, this group of conditions present with lymphoproliferation, which manifests as lymphadenopathy, hepatosplenomegaly, and increased risk of lymphomas, but also autoimmunity. Then the fifth category involves your phagocyte number and function, or both. So this would be things such as severe congenital neutropenia, or in the case of your phagocyte function, it refers to absence in the oxidative burst. Your chronic granulomatous disease falls in this category. And if you had to look at your phagocyte migration to sites of infection, that would be something like your leukocyte adhesion deficiency. And this basically affects the first line of defense. These patients have recurrent bacterial and also fungal infections, but typically also involving then the lung, the lymph nodes, and they present with abscesses as well. So looking at chronic granulomatous disease, obviously here the final step of killing the ingested organism is defective. So these bacteria would remain viable or live intracellularly, survive inside these macrophages. They're not killed off, and then as a result, to try and contain the infection, your body walls it off. So you get multiple granulomas that are formed. The onset is within the first 2 years of life, and again, they would also have lymphadenopathy, hepatosplenomegaly, and chronic infections, usually by low virulent organisms. With your LAD deficiencies or leukocyte adhesion deficiencies, LAD2, for example, you've got the missing ligand. So this involves the interactions between the neutrophils or the granulocytes and the vascular endothelium. So yeah, this first step where you need to have interaction with E-selectin to start the rolling process along the endothelium, that is defective. In LAD1, you've got a missing beta chain in the beta-2 integrin, that's your CD18, that we can flow for and we can detect on flow cytometry, and yet you therefore don't have that firm adhesion between the granulocyte and the endothelium. And for LAD3, the components of the receptors and the ligands are present, but there's no interaction or no activation through this receptor. With LAD3, they can also have defective platelet aggregation, and then they tend to have an increased risk of bleeding. There's 6 categories defects of the intrinsic and innate immunity. So here, if you look at your innate, this is just a simplified sort of student form of how we would divide the immune system, the different arms of our immune system, innate versus acquired. And if you look at innate, this category involves your cells of the innate immune system, typically your natural killer cells, your cell-bound pattern recognition molecules, the toll-like receptors, and also various cytokines and signaling molecules. Again, in this group, you would have your pro-inflammatory response that is defective, because if you to think activation of toll-like receptors trigger intracellular signaling cascades which promote the production of inflammatory cytokines, and then or some of the other toll-like receptors would activate or upregulate the production of type 1 interferons, which ups or upregulates the antiviral response. So these patients again would have recurrent fungal and bacterial and even viral infections. For the autoinflammatory disorders, this is a group that is because of an overactivation of the innate inflammatory pathways. So the difference between an autoimmune disease and an autoinflammatory disorder would be that in an autoimmune disease, there's a mistake in the self versus the non-self discrimination. And this is because of defects in your adaptive immunity. So you'd usually have autoantibodies and specific HLA subtypes that are associated with autoimmunity. But in autoinflammatory disorders, this is the result of an inappropriate activation by your antigen-independent inflammatory pathways, and this involves your innate immune system. So these patients have recurrent fevers or recurrent inflammation of unknown origin. This can persist for months or years. They can have flare-ups and remission in between, elevated inflammatory markers, and they tend to usually have a family history as well. So again, a large number of conditions that fall in this category, usually divided into either genes involving the inflammasome or the interferon production signaling, your NF-kappa beta and tumor necrosis factor alpha activity pathways, or then the miscellaneous group. But ultimately, it's very involved. There's a group that call themselves the Nomad Alliance, Nomad Alliance, but recently they changed their name to the Autoinflammatory Alliance, and they've actually attempted to identify clinical patterns consistent with each one of these autoinflammatory disorders to try and simplify the diagnosis. And as you can see, this is the attempt at simplifying it, so it's very involved and still quite a difficult category to diagnose. The 8th category involves your complement deficiencies. So just briefly refreshing the physiology on your classic pathway starts when your C1 molecule binds to an antigen-antibody complex or any of these molecules that would activate the classic pathway. C1q is this molecule. It looks like an umbrella with 6 identical subunits. It's associated with C1r and C1s. Once bound to the antigen, the C1s becomes activated. It's got esterase activity, and it would then proceed to cleave C4 and C2 to form the C4b2b, which is the C3 convertase of the classic pathway. In your alternative pathway, you've got the C3 tick over. Constantly, C3 is being hydrolyzed, C3b deposits on cell surfaces. It then binds with factor P to be stabilized, so propidin or factor P, that stabilizes C3b on a cell surface. C3b would then bind to the C3, and your factor D will then come and cleave the B to form the C3b-BB, which is the C3 convertase of your alternative pathway. And then they would converse together. You would say they come together where the C3 convertase would cleave C3 and then form C5 convertase to cleave C5, and eventually you get the MAC complex formation, which is the C6 to 9. The membrane attack complex. So if you have early components involved, there's strong association with SLE, recurrent infections by encapsulated organisms. When the terminal components are involved, these patients typically or characteristically present with recurrent Neisseria meningitidis. In the alternative pathway, the propagin or the factor P that stabilizes the C3b initially, and also factor D that is sort of the esterase activity of the alternative pathway. Again, recurrent meningitis being common. And then if you think of the regulators of complement, factor H and I specifically of the alternative pathway. So just showing you again, factor H would bind the C3 convertase of the alternative pathway using DAF, complement receptor 1 and MCPS co-receptors or cofactors, sorry, and then it results in the dissociation of BB from the C3BB. Or alternatively, factor H can bind the C3b, and then the factor I would proceed to cleave this C3b using factor H as its cofactor into its inactive components or the opsonins of C3b. So when they are defective, you obviously have an overactivation of your complement system, and that would present with recurrent, well, atypical Hus, or also known today as complement Hus. The ninth category is the category that involves bone marrow failure syndromes. So these are genetic defects that cause bone marrow failure with an associated immunological defect. There are 4 major subgroups. You've got your Fanconi anemias, the typical, again, clinically, the clinical picture would usually lead you to this diagnosis, the hypoplastic thumbs, the hyper and hyperpigmentation on the skin, the hypercellular bone marrow. The 4th category involving dyskeratosis congenita, myelodysplasia, or defective telomere maintenance. Again, clinically, they could have the leukoplakia, the nail dystrophy, the skin changes. And just to revise, telomeres, these are the structural ends that you find on linear chromosomes, and they prevent loss of genetic material that normally would occur with every cell division. So if you've got improper telomere maintenance, these cells will age quickly and then undergo apoptosis or die. And then there are other bone marrow failure syndromes in this category as well. The last group, or category number 10, is called phenocopies of inborn errors of immunity. So phenocopies occurs when the phenotype is altered by an environmental factor that makes it appear as though the underlying genotype is affected. But it really is because of an acquired condition. So either somatic mutations or autoantibodies that result in disorders that would mimic an inborn error of immunity. So when you look at the diagnostic approach, the laboratory investigations should be guided by your medical history, your clinical presentation, and the type of causative organism. So just looking at your age of onset, for example, you would expect T-cell things tend to occur within the first 6 months of life, whereas primary antibody deficiencies would occur after 6 months when the maternal antibodies have already subsided. Some of your categories where you've got specific syndromic features may help you decide where to start with your investigations. And some organisms could be the typical cyanopulmonary bacterial infections points more toward a humoral deficiency, whereas viral and fungal infections would suggest underlying T-cell defects. Recurrent Neisseria meningitidis would be associated with complement deficiencies. So using your history, your presentation, and the organisms will help you in this process of starting with all the laboratory investigations that are available. But basically, we follow the Jeffrey Model Foundation 4-step approach, and this was adapted for the South African setting by Elliot al, and this was published in the SMJ in 2014. And they start initially just by excluding HIV and atopy, and then just a normal run-of-the-mill full blood count and differential count can give a lot of information. Just a lymphopenia may suggest an underlying SCID. Neutropenia would make you think of congenital or cyclic neutropenia, for example, whereas a neutrophilia may suggest a leukocyte adhesion deficiency, where these neutrophils cannot exit the vascular or the bloodstream. On the peripheral smear, you may see the microthrombocytes that you see with Wiskott-Aldrich syndrome, or these abnormal leukocyte inclusions, for example, in Shiraki-Gashi syndrome. So you can get a lot of information just from a routine full blood count differential and peripheral smear. Part of the step 1 would be then also to do your serum immunoglobulin levels, looking at the different isotypes, but keeping in mind what you expect the range or the level to be for the patient's age, and also for this children that up to 6 months of age, you can still have a lot of interference with maternal antibodies. You can look at the total complement, just to keep at the immunoglobulin levels as a rule of thumb, but being cognizant of the units that are used here and compare this to your laboratory. Usually an IgG of less than 1,000, IgM of less than 100, or IgA of less than 10. That is usually abnormal. Total complement activities and subsequent fractions can be done. So we usually start with your total hemolytic complement, looking at levels of C1 to C9. And then if those are normal, you can look at the functional components of the alternative pathway as well. Do a cystic fibrosis screen and exclude active TB. The second step would be, especially in those patients with recurrent bacterial infections, is to look at antibody vaccine responses, even if they've got normal IgG levels. So you would start by just looking at whether they actually have a proper titer of antibodies, protective titer from previous childhood immunizations that they may have had. And if not, you would then give them a vaccine booster. So we give boosters with your pneumococcal vaccines, polysaccharide vaccines, which would include the pneumococcal or the influenza, Haemophilus influenza vaccine, and also with protein vaccines, so tetanus and diphtheria. And then you would repeat these antibody titers again in 4 weeks' time. You would expect to see in a normal individual at least a 2-fold increase in the antibody levels for polysaccharide vaccines, and at least a 4-fold increase in the protein vaccines. And then, especially in patients, even if the IgG level is normal, but they still have these recurrent bacterial infections, you could look at the IgG subclasses. Another option to do is to look at spontaneous specific antibody titers of IgG. So this is using your blood group isohemagglutinin. This is usually not reliable in children less than 2 years of age. And also, of course, you would not be able to use this for a patient with blood group AB, as they wouldn't have circulating anti-A or anti-B. But in patients with blood group O or A or B, respectively, you would then be able to just look at the antibody titers of the antigens they do not have on their red blood cells. And in children, you should have at least a 1 to 4 titer. And for adolescents or adults, at least 1 to 10 is considered normal. One can also just then do the normal lymphocyte subsets. This is with flow cytometric immunophenotyping. You look at absolute counts of your CD19 positive B cells, your T cells that you can divide into your CD4 and 8 T cell subsets, and also look at your NK cells. And that can give you a lot of information. As we said, currently, it's still part of the diagnostic criteria. An absolute CD3 T cell count of less than 300 is part of the diagnosis of SCID. The third step would be to look at lymphocyte proliferation assays, so your response to mitogens, look at neutrophil burst activity, so the nitroblue tetrazzolium reduction assays, where you use nitroblue tetrazzolium is a pale, sort of colorless to yellow dye that you incubate with your phagocytes or your neutrophils. It's ingested by these neutrophils, and when it gets exposed to superoxide, it causes the deposition, it causes formazine formation, which forms this dark brown pigment deposition in your granulocytes. That's normal. But if you've got absence of your respiratory burst, then no deposits form inside these cells. The same could be done on a flow cytometric platform. You do the dehydrorhodamine test, where again, normal cells, unstimulated, you shouldn't see any increase in the DHR, but once stimulated normally, and these cells produce and have a normal oxidative burst or respiratory burst, you should see an increase in your DHR. But patients, for example, that are carriers, you should see the 2 peaks, and then someone with, for example, X-linked chronic granulomatous disease, regardless of whether they are stimulated or not, there would be no increase in the dehydrorhodamine. We can look at neutrophil studies for leukocyte adhesion, chemotaxis, and phagocytosis. This is done on flow. We basically look for the specific CD markers that you can detect absence thereof. And then for lymphocyte subsets, we can also look at naive versus memory status. So CD45RA is present on naive but mature lymphocytes. Once they are antigen activated, the RA will convert to a RO. And CD27 is a marker of memory status. So the fourth step to then being a bit more involved, you've got cytokine studies, enzyme studies, various molecular investigations. We can also do the T cell receptor excision circles, that's PCR, with a neonatal screen for SCID. These would be absent in SCID, or the kappa receptor deleting circles, excision circles for patients with gamma globulinemia. So this is from the article of Brousseau et al. I just like the way that they didn't put it in 4 separate steps, but it's exactly the same steps. They rather put it in sort of 2 tiers of investigations. The first tier being these screening tests, and then using the results from the screening test with the clinical picture and information you've got to decide which one of the legs of sort of the immune system you're going to go to and which further investigation you'll do in your second tier. This is from an article, a Turkish article that I just thought to show you what they consider to be simple tests, and therefore should actually be available, readily available in academic centers at least, and should be offered to patients that you suspect have primary immunodeficiencies. Again, it's your immunoglobulin levels and antibody responses to vaccines, your absolute B cell counts, The TREC screening for newborns, again, absolute T and NK cell subsets on flow. You should be able to just look at a normal peripheral smear differential count. You can look at either the nitroblue-tetrazolium test or the dehydrorhodamine test to assess for your respiratory burst. Adhesion molecules on flow, bone marrow biopsy to look for bone marrow failure syndromes, and of course your total hemolytic complement. So some of you may have also attended the Euroflow conference last week, and there was a detailed discussion on this new PIDOT tube, so the PID orientation tube. So Euroflow also said that by far the vast majority of all immunodeficiencies are of lymphoid origin, and therefore they started a screening tube to help us identify the most common primary immunodeficiencies of the lymphoid system using a single tube, 8 colors, 12 markers. So just showing you how they subdivided it. Just using these markers, you can identify B cells, the CD19, T cells on CD3, and the T cell receptors with a gamma delta receptor, and then also CD1656 for your NK cells. And then looking further at the T cells, you could subdivide them into CD4 or CD8 positive T cells and memory T cells, which would be the 27 positive versus your naive T cells. And for the B cells, further subdivide apart from memory and naive B cells, you could look at switched versus unclass switched. So if they still express the IgM, IgD, these are unswitched, as opposed to those that are negative, which would be your switched memory B cells. And then they've got a whole algorithm. I'm not going to go into detail, but starting from your PIDOT tube, you could then decide whether, if you think it's primary T cell defect, you can do the SCID mesenchymic immigrant tube, or if you suspect a primary antibody deficiency, they've got a immunoglobulin isotype tube that you could follow. Then just to show what is available in the NHLS, we can do the lymphocyte subsets. So not all the centers have all of these tests available, but most of them have lymphocyte subsets, immunoglobulin levels, and also the IgG subclasses. The total hemolytic complement, vaccine response testing, I think is available at Tygerberg, and then the oxidative burst and lymphocyte proliferation assays. These are not part of our sort of accredited tests, but these are available as part of a research platform at Pretoria and also at WITS, as far as I know. This is from one of the private laboratories, AMPA. They actually have an extensive panel of tests that they offer, and they basically follow the Jeffrey Model Foundation of the 4 tiers of investigations. And they also have a next generation sequencing platform where they test for 99 of the most important genes involved. And PathCare also, again, pretty much the same tests. They've got immunoglobulin subclasses, the vaccine status. They can also do the flow cytometric panels as based on Euroflow. The complement genetic testing for neonatal screening, and also they do genetic panels that they refer to a private company, Invitae, that this is their website where you can actually test almost 500 genes on their primary immunodeficiency panel. So I'm not going to touch on management, it's beyond the scope. I just to briefly mention health maintenance being very important. Of course, in these children, you would want them to have still dental care, visual and auditory testing, not only because of the risk of having abnormalities due to the recurrent infections, but also the chronic antibiotic use that they may be on. Isolation measures being very important, especially if these children are candidates for hematopoietic stem cell transplant. And then there's the argument as to whether you would want to isolate them at home or in hospital. Some doctors would argue that nosocomial infections are worse for these kids than community-acquired infections. But ultimately, you would want your caregiver to basically get dressed as we did now for COVID, mask, gloves, gown, and especially if these caregivers use public transport to reach the patient, they suggest these caregivers should wash and dress in clean clothes before interacting with the patient. I'll briefly touch on immunizations, just to mention also antimicrobial prophylaxis. It's for viral, bacterial, and fungal prophylaxis is used. Immune replacement therapy, Dr. Peter de Waal will touch on that. And then ultimately corrective therapy, which would involve things like thymic transplant, hematopoietic stem cell transplant that's been done successfully also in South Africa. At Groote Schuur Hospital, 3 patients that I know of has been successfully transplanted in recent years. And then of course, gene therapy and gene editing, which is still we're looking to in the future as part of the management. Briefly on immunizations, just for sake of time, I'm going to just highlight basically any live viral or bacterial vaccine is considered contraindicated in patients, obviously depending on the degree and the type of underlying immunodeficiency, but usually we wouldn't give live vaccines. And these patients benefit significantly from herd immunity. So it's strongly advised that all household contacts and also caregivers also be immunized. And then as we are still sort of at the midst of the COVID pandemic, I thought just to mention, the CDC has also now advised all patients with severe immunodeficiencies to be immunized against COVID from the age of 6 months, depending on which product you're going to use. The Pfizer vaccine is available for children 6 months and older, same for the Moderna, but the J&J is only only for patients 18 years and older. And for those that cannot tolerate the vaccine, or those patients where you have inability to actually mount an adequate immune response to the vaccine, there's another molecule available that this was now approved by the FDA in June of this year. It's called Evusheld. It's 2 long-acting monoclonal antibodies that are targeted against the surface spike protein of SARS-CoV-2. And basically, this can be given to these patients, whether they are immunosuppressed because of a medical condition or because they've received significant immunosuppressive medicine. Then finally, just the last sort of leg of management that we always tend to neglect would be the psychosocial support, the family support, and of course, the genetic counseling and testing. Not to forget about that. It's this website, Immunodeficiency Foundation, which is actually a wonderful website with a lot of support groups and a lot of sort of charity events and initiatives to help also support these patients. But finally, just to conclude, inborn errors of immunity are common. It's more common than we realize. And in South Africa, we might be missing it because there's such a high prevalence of other infectious diseases and other secondary causes of immune deficiency. But you should know when to consider it, follow a stepwise diagnostic approach, and know that treatment options are available. And then finally, just to conclude, then the next IUIS conference is actually in 2 weeks' time, and it will be held here in Cape Town. Thank you very much.
Thank you, Anneke, for that truly impressive presentation. That was comprehensive and thorough and very informative. Thank you very much for that. Prof. Louw, if it's okay with you, I think in the interest of time, I think we can move on to the next speaker, unless there are any burning questions for Anneke. Then we'll keep questions and comments to the end after Dr. De Waal's talk. So it gives me great pleasure then to introduce our next speaker, which is Dr. Pieter De Waal, who's also locally here from Bloemfontein. So Pieter qualified as a pediatrician in 2009 here at the University of the Free State in Bloem. And in 2017, he obtained the South African Certificate in Asthma Care. In 2018, he obtained his diploma in allergology from the College of Family Physicians of South Africa, and he qualified as a certified allergologist at the University of Cape Town in 2018. He obtained his MPhil degree in allergology in 2019 and currently works as a full-time subspecialist in allergology at the Bloemfontein Mediclinic. He also holds a part-time post as a senior consultant at the University of the Free State, where he teaches the subjects of allergology, asthma, and pulmonology to both undergraduate and postgraduate students and registrars. And Pieter is also on the executive committees of the South African National Asthma Education Program and the Allergy Society of South Africa. So Pieter, welcome to this forum, and thank you once again for your willingness to share your knowledge with us, especially your practical knowledge on the treatment and approaches to these patients. So thank you, and we're very much looking forward to your talk. Thanks.
Thanks a lot, Jaco. I just want to organize myself here. Good. Okay, good afternoon, everyone. And thanks for inviting me to talk a little bit on practical or just to present a case, a practical case on immunodeficiency or inborn errors of immunity. So the case that I'm going to present is a little girl that I saw last year. I'll tell you about it in a minute. And then I'm also going to talk a little bit about newly published guidelines on immunoglobulin replacement therapy, which in South Africa is really picking up and is becoming becoming a very popular way of dealing with these patients. Okay, so I'm going to give you a short medical history. This is Miss K.M. She was admitted at that stage for a bronchopneumonia in hospital. She's 4 years old. She was born in Lady Grey District Hospital. So she was born in a district hospital, not in Bloem. Normal vaginal delivery, full term, 38 weeks gestation, birth weight normal. Normal APGAR score, so really not a perinatal history that makes you or worried. She was the only child. According to the history, there was no consanguinity. The mum appeared fairly healthy, VDRL, HIV negative, so she was not exposed. There was no family history of note really, and she received all her immunizations according to her Road to Health booklet, including Prevnar. Now you'll see why that part of the history is quite important, and I think Anneke already touched on that. Since the last year, so that was basically since the age of 3 years, she has had recurrent admissions to hospital with so-called pneumonia. She received, on each and every occasion, she received intravenous antibiotics that lasted anything from 7 to 10 days. In between, she generally recovered, but there was recurrent or visits to general practitioners with flu-like symptoms. So I think in between, she was also given courses of oral antibiotics, and she really just didn't get better. There was no symptom-free periods in between. She presented with a very productive cough with copious amounts of secretions. There was also, according to her Road to Health card, there was a clearly, definitely growth faltering, stunting was an important feature. And then importantly from the mum, she was worried about her development, and the main feature that she mentioned, that her child appeared quite weak and clumsy if she compared her to other children of her age. On physical examination, she had a low-grade fever. According to the WHO criteria, she had a moderate acute malnutrition. She was stunted. She had central cyanosis. She appeared chronically ill, actually acutely on chronically ill. There was clear digital and toe clubbing. And then she had a Harrison type sulcus, which in pediatrics is quite a warning sign or a red flag that something chronic is going on. And now she was admitted for the 5th time with bronchopneumonia. So this was a chest x-ray. By the look or just first impressions, nothing really to worry about or to worry about, except for the fact that she had clear signs of bronchopneumonia. And the point that I want to make is actually in children with this type of history, it's important to go look further. So she had a high resolution CT scan, which clearly had radiological features of dilated peripheral airways. So that's a sign of bronchiectasis. So quite important here is chest x-ray gave the impression of air space opacification. There was a bit of hilar fullness. Diffuse bronchopneumonia was reported, and then really on high resolution CT scan, we could see bronchiectasis, both lower and the right middle lobe, a patchy tree in a bud, which is just a term that radiologists use to describe a certain radiological appearance of bronchiectasis, clear consolidation in the right middle lobe, and then other signs or other investigations that were done was a barium swallow, no reflux detected, and a heart sonar, apart from the fact that she had a bit of cor pulmonale and pulmonary hypertension, didn't show any cardiac lesions. Other studies like Anneke mentioned or highlighted, we went through a stepwise approach with her. Full blood count, differential count was normal, which kind of makes you also worried in a child with presenting with an acute infection. Why is her full blood count normal? And why isn't there, for instance, a lymphopenia or lymphocytosis? There was no proteinuria, kidney functions were normal. Albumin, despite looking chronically ill, was fairly normal. She did have higher acute phase reactant, CRP was quite was increased, but the rest pretty much normal. HIV negative, Sweat test, quite interesting, was in the gray zone. So anything a sweat chloride more than 60 millimoles per liter would make you think of cystic fibrosis. So there was still a bit of a debate going on. Why was a sweat test in the gray zone? We were postulating at that stage because that's a false negative, because she was quite malnourished. And then things, or a screening test for alpha-1 antitrypsin deficiency was also negative. So it's important in these patients to take a stepwise approach. Sputum results, quite strikingly, had a lot of organisms, gram-positive and gram-negative bacilli. PJP, Pneumocystis jirovecii pneumonia, which was negative. M. tuberculosis, so a gene expert, was also negative. That was done twice, and I think already done at the peripheral hospitals. But she had a whole zoo of viruses. Human rhinovirus, adeno, RSV, and Epstein viruses were positive. So immediately, this kind of goal gave us the history that there were some red flags going on. She had weight loss, she had recurrent admissions in hospital with pneumonia. There was already digital clubbing, signs of chronic lung disease, and a high-resolution CT scan that showed multilobar bronchiectasis, sputums with multiple respiratory and bacterial organisms. Otherwise, we couldn't find any clear cause for her bronchiectasis. So in a child with this type of history, I think it's important to look for inborn errors of immunity. So this is just my kind of thought process when I see these children, because I keep myself busy basically the whole week seeing these children, and they are children that presents with a history of a recurrent respiratory tract infections or recurrent respiratory problems. So they can be either sinopulmonary, they can be allergy related. So the first question I ask myself, is it normal? So according to the history, according to physical examination, we look, for instance, for red flag signs, things like weight loss, things like symptoms starting fairly early in life and progressively getting worse. A family history, obviously, of any respiratory or recurrent illness will make you worried. Obviously, things like cystic fibrosis needs to be excluded. Then I think for us here in South Africa, it's very important to exclude a secondary immune deficiency first. Secondary immune deficiencies are far more common than inborn errors or primary immune deficiencies. They should be excluded. And then me being an allergist, I would look for allergy as a third step. So allergy often presents with recurrent episodes of sinopulmonary symptoms. When you think about things for asthma, for instance, asthma is not a condition that will give you failing to thrive or growth faltering. Asthma is usually a condition that has distinct episodes of being acutely ill, but in between you thrive and in between you have normal symptoms. So once again, a mom that tells you my child's symptoms started fairly early in life and basically she never got better or she never got normal again is also a worrisome symptom or a history. The other thing that we as pediatricians need to exclude, is it non-immune? Is it either a structural problem with the respiratory system or a congenital problem? Things like branchial arch abnormalities, vascular rings, slings, congenital airway abnormalities, immediately thinking of tracheoesophageal fistulas, those kind of things. And then the fifth step, and that's really because it's kind of a cost-effective way, is to think about primary immune deficiencies, or like we said, inborn, like Anneke said, nowadays we refer to them as inborn errors of immunity. So this is really just a pie graph. It's nothing, there's no numbers linked to it. That's really what I normally see in a daily clinic. The vast majority of children, if you take a good history, do a good clinical examination with no red flags, will then be the normal children. Second most common will be the allergy group. So the allergy group are the children that has either allergic rhinitis, allergic rhinosinusitis, asthma, those kind of conditions. HIV, TB, as secondary immune deficiencies needs to be excluded, non-immune or structural problems. And then really that yellowish kind of part of the pie graph is the inborn errors of immunity. So this is just a broad sort of approach or proportions of patients that we see in a respiratory clinic, specifically in children with recurrent problems. So the basic approach, I think Anneke already talked about this, is firstly exclude secondary immune causes of immunodeficiency. And this can keep you quite busy. I mean, things like HIV, TB, prematurity, children with a stormy neonatal period, ventilated for a long time, that kind of thing is important. Malnutrition, specifically vitamin A deficiency, measles infections, nephrotic syndrome, other protein-using states, respiratory allergy, specifically aero pollutants, asthma, allergic rhinitis, and then the so-called daycare syndrome or the creche syndrome, which is actually allowed to have up to 12 infections per year. It's still considered normal. And that's often what we see in a respiratory clinic. Mom, dad, caregiver, just really fed up with this recurrent type of infections, or specifically upper airway infections that a child has, recurrent episodes of coughing. And when you take a good history and physical examination, you actually find no red flags, and then they will fall then into your normal group. So when to expect inborn errors of immunity, and like I said, Anneke already touched on this, a family history, specifically early sibling deaths or unexplained deaths, that's quite important. Autoimmunity in a young child makes us worried. And then specifically BCG dissemination in infants, especially if HIV negative. And then I want to add a little bit on our spur mnemonic. So serious, persistent, unusual, recurrent, and spur doesn't only sell burgers, it also sells ribs. And the R basically stands for returning in bad shape, a child that you just discharged from hospital in a month or two comes back bad shape. And then a sibling, obviously with any recurrent problems of infection. So let's look at our case study again. So she clearly had an isolated IgA deficiency by the look of things, and that's why it's so important when you see any specific antibody deficiency to look a little bit deeper. And I do advise people always to do subclasses with IgA deficiency. So she had a severe IgA deficiency to such an extent that they couldn't quantify her IgA levels. The rest of her total immunoglobulin levels were normal, but then subclasses, she clearly had an IgG2 and an IgG3 subclass deficiency. So just to illustrate, just remember that, I think Anneke also mentioned this, to look at what your lab's reference range is. Nowadays, most labs use standard or standardized reference ranges. And that's basically when your reference or your value is more than 2 standard deviations between an age-specific value. So it's quite important just to make sure, and these age-specific values are really well published. So just make sure when you label a child as being an Ig or immunoglobulin deficiency that you're actually using the right reference ranges. Quite interesting, she also had some T-cell involvement. Still speculating at that stage whether this was just because she was sick at the stage of presentation, which brings me to the point, whenever you do these levels, try and get your child's general health status as normal as possible. When your child is having an acute viral or bacterial infection, and most of the times we see them when they are acutely ill, and that's where the question comes up, do they have IE or inborn error of immunity? Try and get your patient as normal and healthy as possible, and then do your diagnostic workup. In a child, for instance, that presents with a severe or a disseminated pneumonia, you are going to find skewed up values, either low or high T and B cell values and antibody levels. So if you really have some abnormalities, try and repeat them when the child is normal or healthy. CD4s were slightly low, and total Bs were also fairly low, although not strikingly or worryingly low. So then we did the next step. We did vaccine responses. So vaccine responses generally is to test for responses to protein antigens, and our prototypes is then C. diphtheriae and Clostridium tetani, or tetanus toxoid. So tetanus toxoid is quite a robust protein antigen, and normally we see doubling up at least of your post-vaccination levels. Quite interesting, this girl didn't have any problems with protein antigen protection. She had safe levels right through up until Haemophilus influenza B, which is a polysaccharide antigen, also protective levels. But what she had a problem with was with strep pneumoniae. So she had a specific antibody production problem against Streptococcus pneumoniae, which was basically non-existing. And the lab at that stage couldn't quantify it. They just reported it as insufficient antibody titers against strep pneumoniae. So it's quite important when you investigate vaccine responses to look at protein antigen recognition and response, because that's really your T cell help, but also to look at independent B cell responses, and that's your polysaccharide antigens, which that's why, for instance, Prevnar is a conjugated protein vaccine. That's why we give it in children under 2 years, because they don't really have that immune system or that T cell help as compared to children older than 2 years. So then, because of this, I went back to the patient and I really started examining her from head to toe, which I should have actually done from scratch. And this is what I saw. And I think you recognize now this picture from Annike's talk. She was initially, she was referred to me as an asthmatic with recurrent chest infections, and also she was referred with allergic conjunctivitis. So, I mean, you could strikingly see these dilated capillary vessels on her sclera that ran quite horizontally. The sclera itself remains quite clear, and they were not itchy. They were actually a fairly incidental finding. Mum didn't even notice it. And then I really went into a deeper examination, and she had clear signs of ataxia, intention tremor, struggle to perform the finger-nose test, dysteadicokinesis, and generally she was hypotonic. So these are all cerebellar signs. And then that's really when the penny dropped that this poor girl might have actually an inborn error of immunity with syndromic
In what
features.
situation?
So MRI was done, which clearly showed cerebellar atrophy. The diagnosis.
Sorry, just a quick interruption.
Sure.
Dr. Rahman, can you just quickly mute your microphone, please? Farah? Thanks.
Thanks. And her diagnosis was then, she was then labeled as having ataxia telangiectasia with an IgA deficiency, and specifically an IgG subclass deficiency and other immunological problems. She had a specific antibody deficiency against strep pneumoniae. Quite striking to find a specific antibody deficiency to a certain polysaccharide problem. So she will fall into the category of inborn errors of immunity with specific syndromic features. And then it's obviously, like with these patients, you need to hit the books, read up. Serum alpha protein was reported in numerous of these patients as being strikingly high. The reason being unknown at the moment, the exact mechanism unknown at the moment. We know that serum alpha fetoprotein is already produced in utero by the fetal liver and the yolk sac, and it's a specific marker. You guys probably know more than I do on alpha fetoprotein, but it's a tumor marker that can be used specifically for solid tumors, and also a marker for ataxia telangiectasia. Genetics testing is still pending. I'll talk about genetic testing in a moment, but genetic testing is probably the way forward for this little girl. We do have a diagnosis, but genetic testing will just confirm which specific gene mutation is present. So just a quick look on AT. It's a chromosomal breakage disorder considered rare. There's a defective DNA repair mechanism. Abnormalities basically in your DNA goes unchecked. Autosomal recessive inheritance. The stability of the chromosome is then decreased, multiple rearrangements, and it really comes, I think Anneke also mentioned this, it comes from the ataxia telangiectasia mutated gene on chromosome 11, where you basically have unprotection of your, or non-protection of your genome, and basically chromatid breaks and also neuronal damage can follow. They are also abnormally susceptible to X-rays, for instance, and that's why we try and minimize X-ray exposure to for these children. Skin signs are really ataxia later in life. Early in life, they can present with ocular telangiectasia, which is these dilated conjunctival vessels that kind of runs horizontally in the eyes from the outside or the outer canthus of the eyes. It runs medially. There can also be other telangiectasia, the ears and the eyelids, typically sun-exposed areas. And then what we often see is, or can see, is café au lait spots, or just hyperpigmented macules, or even vitiligo. So skin signs are really the giveaway here. Immunological problems, really a broad spectrum. They typically have IgA and IgG2 subclass deficiencies, and they might even have that in normal IgG levels, total IgG levels, and that's why it's so important to go and look for that subclass deficiency. Susceptibility to polysaccharide antigens, defective IgM class switching, so they can often have normal, even high IgMs despite having low IgA and IgG levels. Lymphocytes might be decreased, and they have a recurrent sinopulmonary infection risk, either from viral or bacterial origin. They typically present with chronic lung disease and bronchiectasis. We'll talk about lifelong immunotherapy replacement in a minute, and often they can present with allergy, autoimmune disease, and then leukemias and lymphomas later in life. So what's currently the plan for this patient's intravenous immunoglobulin replacement therapy? She's receiving that on a monthly basis, fairly high doses of 600 milligram per kilogram. For her bronchiectasis, obviously home oxygen, antibiotics. For exacerbations, that will be based on a very low threshold for antibiotics, often longer courses. And she will also receive then prophylactic antibiotics, which will be given to her on a Monday, Wednesday, or Friday, or 3 times a week basis. Respiratory rehab for her lungs. Her mum is currently receiving home or received a home physiotherapy program, and then a dietitian is also involved in her management to get a nutrition optimal. She will be followed up for solid tumors, specifically leukemia, lymphoma. Genetic counseling was done. She needs to be counseled for with regards to a future pregnancy, because this is an autosomal recessive condition. We registered her on the South African Inborn Errors of Immunity Registry patient support group. I'll give you the website at the end. And then prognosis of AT, unfortunately, is terrible. There's no curative treatment, and the mean survival age all globally has been reported as 19 to 25 years. So really a terrible diagnosis to have. So I thought to talk to you about a little bit about immune replacement therapy. So it's actually fractionated from donors or from donated human plasma. Quite importantly here, it's indicated only for humoral immune system defects. It's not indicated at all for T-cell immune defects. Early administration has been shown to improve quality of life, prevents hospital admission and organ damage, and it can actually be life-saving. So as soon as possible, try and make the diagnosis of an inborn error of immunity. And if your patient qualifies, then let them start immunoglobulin replacement therapy. So these are just the new updated guidelines, which were published, I think, end of last year. It's really a collaboration between the Allergy Society of South Africa, the Primary Immune Deficiency Disease Society of South Africa and the Allergy Foundation of South Africa, which is a group of people that came together and specifically in the South African context published the guidelines. So who will benefit from immunotherapy or immune replacement therapy? This is kind of a new phenotypical classification, also, by the way, has been used by the Americans. So it's a phenotypical classification that helps us decide who really needs immune replacement therapy. So the first group of patients, or the first phenotypical group of patients that will benefit, will basically be our category 1 with absent B cell numbers, quantity of IgG, so that's your total quantity, but also IgG function problems. So that's specifically your antigen recognition and responses to vaccines. So that's your first category. They are obviously the patients that will need lifelong replacement or immune replacement therapy. Our category 2, those are the patients with present B cells with low IgGs and both quantity and specific vaccine responses. So things like common variable immune deficiencies. They are patients with IgG deficiency, either function or number. The NEMO subset, a terrible condition that basically have a problem in your innate immunity, where they have also IgG total or function deficiency, will also benefit from that. Category 3 and 4 patients are patients that may or may not benefit. And these are the patients that you clearly should investigate whether they really have IgG quantity or a function problem. If they have one of those two, they will benefit. And those are the patients that you will probably give immunoglobulin replacement therapy for about a year. And then you will see what the responses and what the history of the infections will be. So here we often see transient hypogammas. So transient hypogammaglobulinemia is something that I think we see more often than we realize. And these are the children that has got sort of lagging immunity, specifically antibody either production or function. And as they get older here, by 3-4 years of age, their antibody production and function kind of normalizes. It's quite important to take a good history and to really determine in these children if recurrent infections is a problem in a child that has been hospitalized once or twice before the age of 4 years just for a tonsillectomy or for a 3-day course of antibiotic. They will definitely not qualify as for immunoglobulin replacement therapy. But children with recurrent infections due to primary or transient hypogammaglobulinemia will definitely then benefit from immune replacement therapy. So just a quick word on vaccine responses. So vaccine responses are really a developing field. And it seems like the immunologists are not quite clear on guidelines. And it also seems like certain phenotypes, certain endotypes of inborn errors of immunity patients follow different kind of patterns of what is protective and what is not. And you cannot really do this as a blanket approach, but what has been published recently is that in each and every child with a possible antibody deficiency, it's also important to not only look at the levels of IgG, but to also look at the function. So here with vaccine responses, we evaluate or we interrogate functional IgG or the function of the IgG. Remember that patients with a low total IgG deficiency or a subclass immunodeficiency may also respond poorly to protein or polysaccharide vaccines, like we've seen in this little girl. Generally, it is acceptable if your IgG to strep pneumonia is about 1.3 micrograms per mole or higher following polysaccharide immunization. So once again, remember the difference between Prevnar and Pneumovax 23. Prevnar is a protein conjugated vaccine. Your immune system or B cells gets a bit of T cell help. And that's why we immunize children under 2 years with Prevnar. But in older patients, we use a polysaccharide vaccine, which will then be a T-cell independent kind of mechanism, testing T-cell independent function. So if your baseline is less than 1.3, fold is irrelevant as long as you've reached your 1.3 protective level. If your baseline is more than 1.3 before vaccination with Pneumovax 23, a twofold response is then acceptable. Remember, in children older than 2 years, if they received only Prevnar, 0.35, because it's not such a robust vaccine, any level above 0.35 micrograms per mol against strep pneumonia is then protective, and a twofold elevation after vaccination is then acceptable. Nowadays, we can even break it down into Streptococcus pneumoniae serotypes, where you give the most, or where the laboratory can do serotyping, the 13 most prevalent serotypes. And you can even physically go and count which serotypes actually boosted after vaccination. So in children under 6 years, we expect them to have at least 50% of that serotype should show a twofold increase. And in older children, at least 70% of those serotypes should have at least a twofold increase. And that's once again after Pneumovax 23, which is a polysaccharide. It's a T-cell independent vaccination. It is also recommended to retest children after 6 months. Retest if that vaccines are still, or that IgGs are still holding. Some patients may actually show what we call waning of immunity. Their immunological memory wanes over time, and it's quite important that you, specifically patients with combined variable immune deficiency, might have a waning immunity that you need to pick up. What products are available on South Africa? I think the most well-known one is the Polygam. I think important here to remember, Polygam is only given intravenously. It's got an incredibly low IgA content, and that's why we don't give intravenous replacement or any immune replacement therapy for children with low IgA levels in isolation. If you have a patient with IgA level which is low, go and test for IgG, because that's actually what you are replacing by giving immune replacement therapy. That's just the average cost, and I think this was published a year or two ago, the average cost of a 70-kilogram adult, and then also the total cost for lifelong immunotherapy. So it is kind of an expensive exercise, but it has been shown to keep your patient out of hospital. So it is cost saving at the end of the day. Intragam, Octagam, Beriglobin, I think all of us has probably heard about Beriglobin, completely misused and abused during the COVID pandemic to such an extent that intravenous replacement or replacement therapy was not available, was out of stock for a while. Please remember, it's not for viral infections. It's not for any other immune deficiency. It's only for IgG and antibody deficiencies. Obviously, the benefit of Beriglobin, for instance, it can be either administered subcut or intramuscular. The two main routes of administration is either intravenously or subcutaneously. Nowadays, we even have the option of fractionated subcutaneous immune replacement. Definitely some big advantages of subcutaneous immune replacement therapy above intravenous immune replacement therapy. Unfortunately, subcutaneous immunoglobulin replacement therapy are still not covered by medical schemes. It's a more expensive, unfortunately, it's more expensive, but one of the big advantages of subcutaneous immunoglobulin replacement therapy, it can be given at home, and it's as effective as subcutaneous or intravenous immunoglobulin replacement therapy. You do need venous access. There's a few patients up north where they really live in shacks and in harsh circumstances where mums actually manage to give intravenous immunoglobulin replacement therapy, but they need to be taught very, very well. Adverse effects, obviously less with subcutaneous immunotherapy compared to intravenous immunoglobulin replacement therapy. Dose intervals, and this is one of the biggest advantages of intravenous replacement therapy. It can be administered 3 to 4 weekly, where subcutaneous immunoglobulin replacement therapy is given then either weekly or bi-weekly, dependent on your patient's response. Another big advantage is the peak trough level variation in IgG. So unfortunately, a fairly high peak and then quickly waning of IgG levels shortly after your infusion stops. And the half-life is about 21 days of IgG. So we get that peak variation trough, which is much higher in intravenous immunoglobulin replacement compared to subcutaneous. So subcutaneous, far more stable. You reach a stable trough level and it kind of stays for a longer time in that specific level. Subcutaneous immunoglobulin replacement therapy, really nothing sinister about it. It basically is the same as administering insulin to a diabetic patient around the umbilicus, upper thighs, even posterior upper arms. It's usually administered by either 1 or 2 butterflies, depending on your dose. So your total dose will then be divided into 2. You can either give it through infusion pumps, but most patients on subcutaneous immunoglobulin replacement therapy nowadays just give it very, very slowly with the push technique. Unfortunately, local erythema, local induration, side effects quite common, and that's really dose dependent and also rate dependent. So it's really an easy way of administering. And like I said, the main advantage here is that your patient can actually do this at home, which they don't need to be admitted for or come to hospital for it. What about monitoring? Now you've decided to put your patient on immunoglobulin replacement therapy. I think before you start, screen for hepatitis B, HIV, and TB. That's kind of standard practice. Have good copies or electronic records of infusions, adverse reactions, blood tests done, and then 6 monthly monitoring of full blood count to check for anemia, cytopenias, check creatinine levels, specifically in patients with renal or that has got renal impairment. LFTs, I think LFTs are more useful to detect early viral hepatitis type of pictures, but LFT is not really important in terms of IVIG side effects. And then other patient support groups like Anneke said, the Primary Immunodeficiency Network of South Africa, and then International Patient Organization. So how do we actually monitor our trough levels? How do we monitor how our patient is doing? Sufficient levels are unfortunately of IgG is not yet established. Like I said, it seems like different phenotypes, individual patients respond differently to the susceptibility of infections, and they require different protection levels. So to kind of have a standardized cut-off level is fairly difficult. Trough levels should be monitored monthly after IRT initiation. And once you've reached your steady state, you will see basically your patient remains on the same level of IgG. You can do that 6 monthly and even yearly. Thereafter, it's really a matter of having a good eye on your patient and monitoring your patient really for breakthrough infections. The guidelines currently say trough infections of IgG levels of about 6 to 8 will be sufficient. Higher levels may be needed in selected patients. So if you have a patient, for instance, with an IgG trough level of 7 grams per liter, but still has recurrent breakthrough infections, you should probably aim for 3 weekly instead of 4 weekly, and then aim for higher doses and higher IgG levels. Subcutaneous immunoglobulin replacement, and that's also an advantage, really has been shown to increase your IgG trough levels quite dramatically, and you can even reach levels of up to 10, 11 grams per liter. Obviously, remember, for a specific antibody deficiency, IgG levels are not valid, and you should basically base your frequency and dose on your patient's history of infections. When to stop? Like I said initially, that class 1 and 2 patients will receive lifelong immunotherapy replacement. Class 3 and 4 is really that patients that you can give for 12 months immunoglobulin replacement, and then evaluate the immune responses 6 months after the last infusions, check if that IgG is holding, and then really, if a good response is reached and still your patient still remains infection-free and IgG level holds, then you can stop with a careful wait and see approach. Obviously, after humoral reconstitution, after hematopoietic stem cell transplant, it's also advised to stop immune replacement therapy. Like I said, ideal IgG levels post-cessation of IRT is not clear, and indications to restart is based on your patient's frequency and severity of infections. It's not to say if you stop your patient's IRT, it's going to be stopped forever. You are allowed to restart it based on your patient's history. Just additional treatment options, I think keep a close eye on what is happening in the respiratory tract. Often the same as we do with patients with cystic fibrosis, we give them longer courses of antibiotics. We culture their sputums. We need to see what's happening in terms of susceptibility and organism resistance. Prophylactic antibiotics are really indicated for patients with antibody deficiency. Azithromycin is a macrolide broad spectrum, also has anti-inflammatory properties, given 3 times weekly. The current evidence is still that antibiotic resistance is not a big problem when given at 10 milligram per kilogram 3 times weekly. And then we have this big debate going on, and this is often where we as pediatricians need to decide, listen, are we really going to do a seasonal prophylaxis? These children that does not seem to get better with either a transient hypogamma or a transient hypogamma or an isolated IgA deficiency, are we really just going to get them through the winter season until it's summer and then stop their prophylaxis? Unfortunately, no clear guidelines on that. For T-cell deficiencies, Bactrim still a good drug daily, and for chronic granulomatous diseases, a mixture really because they have fungal and bacterial susceptibility, Bactrim and the antifungal prophylaxis, that's given daily. And then your terminal complement deficiencies, specifically C5, C6 being susceptible to Neisseria meningitidis, penicillin is then given twice a day, basically lifelong. And like Anneke also said, infection control, very important. The concerns about a live vaccination, in children with inborn errors of immunity, there's a list that you can go through. Basically, it's live viral and bacterial organisms are a concern. Antibody deficiencies, specifically when it comes to IgA and IgG subclass deficiencies, it's really bacterial infections or live bacterial immunizations that's a concern. And it seems like OPV and other live viral vaccines are safe. T-cell immunodeficiencies, try and avoid all live bacterial and viral vaccines. And then things for like interleukin-12 pathway, which we all know makes you susceptible. For instance, it's a Mendelian susceptibility to Mycobacterium disease. These patients have a problem with activating their macrophages and interferon gamma. That problem, so BCG is then contraindicated in these patients. Genetic testing is really the way to go. So far, we've been really relying on clinical picture and antibody.
Peter, I'm sorry. Peter, yes. Sorry to interrupt you. We've unfortunately run out of time already. So if you can maybe just summarize and close for us in a minute or so. Yeah. I'm so sorry to do this. Your talk is truly fascinating, but we've unfortunately run out of time a bit.
Yeah, no, sure. This is actually my last slide.
Oh, okay, so, great. Thanks.
Yeah. So please feel free to contact Empath Immunology. It's an in vitro test. They do it now. There's about 200 of different genes that they can test for. Unfortunately, there is some costs involved, but it will really help to pinpoint your patient's immunodeficiency into a more accurate diagnosis. And this is my last slide. So this is from, this is helpful links for you dealing with possible patients, either for clinicians, South African Society. I think we've got our societies up and running now in terms of dealing with these patients and also support. And please remember to register your patient. A specific gene or a genetic diagnosis is not necessary, but specifically when it comes to patients with immune deficiency, the more we register these patients, the more people can see how many South African patients has got IE, inborn errors of immunity, the more we can motivate for things like replacement therapy and stem cell transplants. And that's my story. Sorry for going over time.
Thank you, Peter. Thank you very much for that very interesting case and comprehensive overview of the management. These are important conditions. We unfortunately have run out of time a bit. So I would propose that if you've got burning questions that are still not answered, then we can perhaps arrange for you to send your questions to Peter via me or Anneke. You can send your questions via email to me, and then I will get it to Anneke or to Peter so that they can give it its due consideration. So with that, it just remains for me to thank our two speakers again. Anneke van Marle, thank you very much for your excellent talk, and Peter de Waal as well for your truly excellent talk. And then if I just would like to remind everybody to click on the CPD link that's in the chat box, and then we can close the session. And thank you very much once again to the Deep Dive team for inviting us to participate on this platform. And if with that, I think we can close this session, and everybody must have a wonderful evening and travel safely. Thanks, everybody. Bye-bye.
Thanks, Jaco. Thanks, everyone.